Welcome back to our second installment on the physiology and pathophysiology of the endocrine system with some anatomy review. In this picture, I'm trying to show you hypothalamic control of hormone secretion. And if you look carefully up at the top of this slide, you're seeing the hypothalamus in a purple box, and you're seeing neuronal cell bodies that are colored in blue and neuronal cell bodies that are colored in green. And these two sets of neuronal cell bodies are showing hormones that can be directed for release through neural control. So the hypothalamus, this picture is showing you basically how it's hardwired to the adrenal medulla and leads to epinephrine release. The hypothalamus is also, it extends posteriorly as the posterior pituitary. And in the posterior pituitary we see synaptic ends where ADH and oxytocin are stored, and they are released really as neurotransmitters but directly into the bloodstream, so that makes them hormones. And a lot of times students make the mistake thinking that the posterior pituitary is a gland that makes and releases hormones, and it does not make hormones. The hormones are made by these neuronal cell bodies up in the hypothalamus, and these hormones are merely stored in synaptic vesicles that are found in the terminal bouton back here in the posterior pituitary. So the posterior pituitary is technically an extension of the hypothalamus. Now shown here in the dark crimson red arrow is showing a hypothalamic control pathway where hormones released by the hypothalamus direct the release, or not, of hormones that are made, stored, and released by the anterior pituitary gland, which was actually formed when you were a developing embryo and fetus from arches in the back of your mouth, back when you looked more like a fish than a human. So it's weird to think that this came from the back of our throat and then rose superiorly to take up residence in the hypophyseal fossa of the sella turcica in the cranial cavity. So there are 7 hormones that are made and stored by the anterior pituitary, and I always remember them through a mnemonic, and I remember melons grow and produce through late fall, where melon stands for melanocyte stimulating hormone, grow stands for growth hormone, through stands for thyroid stimulating hormone, late stands for luteinizing hormone, fall stands for follicular stimulating hormone, and I forgot to. Melons grow and stands for ACTH, adrenocorticotropic hormone. So melons grow and produce, P for prolactin. Now what do these hormones do? Well, some of them are going to act on a third endocrine gland. For example, the hypothalamus will release something called corticotropin releasing hormone, and this causes the anterior pituitary to release ACTH, which in turn targets a specific layer of the adrenal cortex to release glucocorticoids, most notably cortisol. Or the hypothalamus releases thyrotropin releasing hormone, which targets the anterior pituitary to release TSH, which targets the thyroid gland to release the thyroid hormones known as T3 and T4. You get the idea. Now melanocyte stimulating hormone will actually stimulate melanocytes and alters the pigment of skin, but this really is important in a fetus. We're really not sure what it does in normal healthy adults. However, you will see in some of the pathology of the adrenal gland that ACTH and MSH are cut from a much larger protein precursor called POMC, or pro-opiomelanocorticotropin. And you could think of ACTH being cut out of that large protein precursor as a little cassette. And MSH is also right next to the ACTH. And when ACTH is cut out, some MSH hormone is cleaved out with it, meaning there's overlap. And you will see then when someone has excessive production of ACTH, they're going to have hyperpigmentation because the melanocytes are stimulated enough by just this little bit of shared overlap of ACTH and MSH. We're going to go through a lot of these HP, whatever third downstream gland in greater detail. So I will focus on the next few slides on the HPT pathway. And once we learn those rules, they apply to other HP blank pathways like HPA, HPL for liver, and HPG. A terminal hormone is called prolactin. When it's released by the anterior pituitary, this stimulates mammary glands for milk production. Oxytocin is required for smooth muscle in mammary glands to release milk. Oxytocin is considered to be, just to highlight it a little bit, a quote-unquote social hormone, increases feelings of well-being, but it's really mostly important for contraction of smooth muscle. This is, of course, important for labor and delivery, and also for orgasm in the case of ejaculation in males. So I always sing to my physiology students. I say, N for neurohypophysis, which is another term for the posterior pituitary, A for ADH, and O for oxytocin. And I sing the Banana Boat song, which is supposed to be Day-O, Day-O, but I sing Nay-O, Nay-O, N for neurohypophysis, A for ADH, and O for oxytocin, of course. ADH will make you swell, oxytocin you scream like hell, because whether you're female delivering a baby or ejaculating if you're male, you're screaming either way. And the ADH is to symbolize the swelling part, that your kidneys will retain more water and your blood volume and pressure will go up. So it gets a good laugh with my face-to-face students, and I hope I made you giggle on this PowerPoint presentation through YouTube. A little colored joke, of course, but that goes a long way. So let's focus on our HPT pathway. It's important to realize as we go through these HP, fill in the blank for third endocrine gland pathways, these hormonal pathways, that we're talking about the hypothalamus starting the signal. And it initiates with the hypothalamus releasing trophic hormones, which means these hormones are released into a capillary bed, which then the blood travels a short distance to the anterior pituitary. And in this picture you're seeing different camps of cells. And each camp of cell is responsible for making one or more of those 7 hormones I just told you about. So you might have somatotropes that are making growth hormone. You might have thyrotropes that are making thyroid-stimulating hormone. You might have melanotropes that are making melanocyte-stimulating hormone. You get the idea. Now the other side of this picture, you're seeing the hypothalamic cells with axons that extend all the way to the posterior pituitary, where they release their hormones directly into the bloodstream. This second capillary bed here would also be found on this side. We're not going to entertain this neural pathway right now. We're going to focus on the HPT pathway. Now, when scientists see a double capillary bed in tandem, we get very excited. This is called a portal system, 2 capillary beds in tandem. Now, this is a venous portal system because we have an artery leading to a capillary, a venule, which it should be, but it leads to another capillary and then another vein. So this is a venous portal system. We see venous portal system through the hepatic portal system, and we're also going to see an arterial portal system when we're learning about renal physiology and pathophysiology. All right, next layer, concept layer. These hormones that are released by the hypothalamus that direct anterior pituitary hormone release or not, these hormones are named, and they have terms added to the names. For example, such and such releasing hormone. Well, if the hypothalamus releases a releasing hormone, then that's going to give permission to the certain camps of cells in the anterior pituitary to release their hormone. But if the hypothalamus releases such and such inhibitory hormone, then that tells these camps of cells, no, you cannot release them. Now, students oftentimes predict the following: that the hypothalamus has growth hormone releasing hormone, and that would stimulate the somatotropes to release growth hormone. That's true. Then they say the hypothalamus also has growth hormone inhibitory hormone, and another name for that is called somatostatin, and that is true. And that means the somatotropes down here would not release their hormone. However, this system does not apply toward all 7 hormones that are released by the anterior pituitary. Let me say that again another way. The default for these camps of cells is to not release their hormone unless the go-ahead, the go signal, is received from the hypothalamus. Some hormones made by the anterior pituitary have an extra safety mechanism where it's not just the default, you can't release unless you're told it's okay to release, but some of these camps of cells have an extra set of instructions saying, you are inhibited. No way are you allowed to release this. So I'm sure you appreciate that, especially if you're male, when there is a prolactin inhibitory hormone. You certainly wouldn't want the cells to escape that extra safety mechanism and suddenly start to produce breast milk. And another term for prolactin inhibitory hormone is dopamine. So there are releasing hormones released by the hypothalamus for those 7 anterior pituitary hormones, but not all 7 have a hypothalamic inhibitory hormone. Again, the default is they cannot release until told it is okay. So we're going to explore specifically the hypothalamal hypophyseal thyroid axis, or HPT axis, and the chain of command is shown here on the screen. The hypothalamus will signal the anterior pituitary. How will it do this? It'll release into that first capillary bed. By the way, this capillary system, double tandem system, is called the hypothalamic hypophyseal portal system. Okay, so the hypothalamus is going to release in the first capillary bed TRH, thyrotropin releasing hormone. And the anterior pituitary, in turn, will release thyroid stimulating hormone, or TSH. This is distributed into the second capillary bed and goes all throughout the body. It will then bind to receptors on the thyroid gland, and the thyroid gland will respond and make thyroid hormone. And the question I ask my students is, do you think the hypothalamus or the pituitary or the thyroid has eyes, nose, ears, or fingers to know how much hormone it's releasing, if any at all? How does it know when to stop secreting? How does it even know how much it released in the first place to signal the downstream gland? And the idea that is really important that you understand is, on each of these glands, they have receptors. The hypothalamus has receptors for its own hormone, TRH. And some of this hormone, when it's released into the bloodstream, travels all throughout the body and will come back full circle and ultimately bind to receptors in the hypothalamus. The more receptors bound to its own TRH tells the hypothalamus, what a good gland am I. I've sent a signal, let's hold tight and see if the downstream endocrine glands listen to me, obey me. Similarly, when the anterior pituitary releases TSH, it too has receptors for its own hormone. And when those are populated, the anterior pituitary, if it could talk to you, would say, what a good gland am I obeyed the TRH. But some of this TSH also populates receptors found on the hypothalamus. And that's the way the hypothalamus, quote-unquote, knows that the anterior pituitary received the signal TRH and obeyed it by releasing TSH. Similarly, the ultimate goal is to get the thyroid gland to release thyroid hormone. And in turn, this hormone can feed back and populate receptors on all of the upstream glands, even itself. The population of receptors by these hormones is the only way that the endocrine gland can, quote, detect, sense how the levels of these hormones in the bloodstream. So this really needs to be talked about some more. In other words, there's this long feedback loop. Ultimately, the hypothalamus is sending all of these signals, and the anterior pituitary is responding to it, to get the feedback that thyroid hormone levels are going up in the body. And if the thyroid hormone levels go up appropriately, this will feed back, populate receptors in the hypothalamus, and will then in turn inhibit further release of TRH. Lack of TRH inhibits the release of TSH, and then that will shut down the release of thyroid hormone, because after all, enough is enough. There are shorter feedback loops, like I described in the previous slide, so that the upstream glands can detect how much of their signaling hormone they released. So all these feedback loops, they are properly called negative feedback inhibition. And when we go through the pathology of the thyroid gland, you will see that there's negative feedback inhibition failure with some diseased states, where the shutdown or turn on signals are not being made or released or responded to appropriately. Maybe this is a new topic for you or a new way of thinking about the endocrine system, so let's play. Let's start with an easy disruption in this pathway. This is a chain of command. Let's say on this side we're going to use arrows to describe the levels of hormones like TRH, TSH, and TH. And this chain of command shown in green is showing hypothalamus signals anterior pituitary, which signals the thyroid gland. So in the left, we're going to play with the idea that the thyroid is overactive. Maybe there's an over-secreting tumor in the thyroid. On the right side, we're going to use arrows to describe hormone levels at each level in the body if the thyroid had an under-secreting tumor. So let's start with the left side of our screen. Now I'm telling you where the disruption begins, so that's your starting point. We have an over-secreting tumor in the thyroid. So tell me, what would the levels of thyroid hormone be like in a patient with this situation? Would they be normal, lower than normal, or higher than normal? That's right, they'd be higher than normal, so put an arrow pointing up on the left of your paper. Now, feed back to the hypothalamus. How many receptors on the hypothalamus are going to be populated by this excessive thyroid hormone? Probably all of them. And how will this healthy hypothalamus respond? Should it increase release of TRH or decrease it? That's right, it should decrease TRH, so levels would be lower than normal. Hypothalamus is trying to put on the brakes on the system. What do you think the anterior pituitary will do with respect to TSH? Should TSH levels climb in the blood or be reduced? No release. That's right, it too would go down. Now, in a healthy person, the lack of TSH should shut down the thyroid. And it's not, because we've got a tumor here. Remember, that was our starting point. So this is negative feedback inhibition failure. We're not getting the whole loop. The whole loop is not responding appropriately. One of them is just throwing up its middle fingers and saying, poo-poo to you, I'm not going to listen to you. Can you do the same thing on the right side of the screen? Now we have an under-secreting thyroid tumor. That can happen too. Cancerous growth that's causing disruption of normal cell behavior. So that's your starting point. What would happen to levels of thyroid hormone in the blood? Would they be higher, normal, or lower than normal? That's right, they'd be lower, so put an arrow pointing down. How many receptors in the hypothalamus would be populated by thyroid hormone? Not a lot. And because very few of them would be populated, what would this do to the hypothalamus? What does this quote say to the hypothalamus? It would say, raise the release of TRH. So TRH levels in the blood would go up, make an arrow going up. What would this do to the anterior pituitary? It would also cause TSH levels to go up. But in theory, this should cause thyroid hormone levels to go up too, but because of the cancerous growth, TH levels are not. And this is again a disruption in normal negative feedback inhibition failure. We're not getting TRH levels to an appropriate level to inhibit the hypothalamic and anterior pituitary signaling. You can do the same thing where the break, the disruption starts in the anterior pituitary. Again, there can be an over-secreting tumor of the thyrotropic cells there. There can also be an under-secreting tumor of the thyrotropic cells. If it's too much secretion, then TSH levels would be up, thyroid hormone levels would be up, this would feed back and inhibit the hypothalamus, TRH levels in the blood would go down. On the right side, with too little activity, TSH levels would go down, lack of signal to the thyroid gland means TH levels would go down more than normal. Lack of receptors populated by TH on the hypothalamus would stimulate the hypothalamus to increase levels of TRH. Those levels would be very high in the blood. And then finally, we could do this all over again with a focus on the hypothalamus if it was disrupted by an over-secreting tumor or under-secreting tumor. And this is easy. If the hypothalamus releases too much TRH, TSH levels would be too high, thyroid hormone levels would be too high, and that should turn off the hypothalamus, but it has cancerous growth. Over here, too little hypothalamic activity, TRH levels would go down, TSH levels would go down, thyroid hormone levels would go down. It's important to understand this normal feedback loop and disruptions of it, because when we speak of an overactive thyroid or underactive thyroid, it doesn't necessarily mean that the thyroid was the gland that started the whole problem. And when we speak of hyperthyroidism and hypothyroidism, of course we'd like to know exactly where in this loop the dysfunctional gland was so that we have options for treatment. And we're going to talk about this in the next few slides. Can you apply the same kind of concept to the HPG pathway before I show you the rest of the thyroid gland and how thyroid hormone is made? With the HPG pathway, we have the hypothalamus releasing gonadotropin releasing hormone. This stimulates the anterior pituitary to release hormones that stimulate in the woman gametogenesis, making oocytes, and that's FSH and LH. And when those are released, then the ovary produces several follicles. They start to mature, and then the release of an oocyte into the uterine tube. Some women take birth control. This is a high level of estrogen and progesterone, which are hormones made by the ovary in response to LH and FSH. If you take a high level of estrogen and progesterone in birth control pill, those hormones feed back to your hypothalamus as if they were your very own estrogen and progesterone coming from your own ovaries. How do you think your endogenous HPG pathway would respond to this? This would be a significant level of negative feedback inhibition in the form of that birth control pill. Endogenously, the woman, her hypothalamus would shut down release of gonadotropin releasing hormone. And this would shut down release of LH and FSH from the anterior pituitary. And this means her ovaries are not going to respond to those two hormones and not ovulate. In other words, this birth control pill is really, quote, tricking her brain, her hypothalamus, that she's already pregnant, and it would not be appropriate to ovulate again while currently pregnant, right? So that's how birth control pills work. Now, can you think of other examples where someone might be taking an external, exogenous source of a hormone? Yes, some people do take exogenous thyroid hormone. Some people take exogenous cortisol, a hormone that plays a role in the HPA pathway. Now, what's the worst that can happen to a woman if she suddenly stops taking her birth control pill? She might get pregnant. But what's the worst that can happen to someone if they suddenly stop taking cortisol that they might be on for months, say for an autoimmune disorder? Most of the time, a woman who stops to take her birth control pill, we think, oh, she could get pregnant. But someone who stops taking cortisol cold turkey, it's life-threatening or has the potential to be. So we don't think of stopping to take your birth control as life-threatening typically, though I would make that argument. But certainly with other hormones that are given exogenously through physicians' prescriptions, if they stop them cold turkey, it could be life-threatening. And we'll explore that in our third segment. Here's a picture of the thyroid gland, and the chapters that I have on these slides correlate with the 12th edition of Guyton and Hall. They don't necessarily go with the pathophysiology book that we use. And you're seeing these repeating circular structures. These entire repeating circular structures are called follicles. And the cells that line these circles are called follicular cells. And inside the middle of these circles is a space that's filled with a proteinaceous soup. What does that mean? It simply means an aqueous solution that's very, very concentrated with protein. So the next time you eat chicken noodle soup, I want you to say to yourself, I'm eating a proteinaceous soup. And down here in this picture, we're going to expand a region of this follicle. And we see a blood vessel here, and we see a follicular cell. And down here at the bottom of the screen, this would be where that purple colloid that you see up here would be. So the side of the cell that faces the blood vessel, that's the basal side or the bottom side. The apical or top side of these follicular cells surround and face the lumen of this colloid space. These cells get ingredients from the bloodstream to make a very large protein called thyroglobulin. So they get amino acids from the blood, but they also get iodide. And the iodide is internalized into these cells and then extruded out the apical side. Thyroglobulin is also exocytosed. And when thyroglobulin, this long, large protein of over 3,000 amino acids, which is highly populated by an amino acid called tyrosine. And when this thyroglobulin precursor is exocytosed, hanging out here on the apical membrane are enzymes that take the iodide and they attach it to the tyrosine residues. And they might get one iodide attached to a tyrosine, and that's called monoiodotyrosine. Or these enzymes might get two attached, and that's called diiodo. Or they might get three attached, triiodo. Or they might get four attached for tetraiodo. So all combinations are made. Now the question is, which of the tyrosine residues with the iodides attached are actually thyroid hormone? And it's the ones that have T3 and T4. And let's look at this in greater detail. Up here you're seeing a tyrosine residue, and you're seeing that it can be iodinated on the benzyl ring. The better word for this process is called organification. Don't let the word scare you. Organification simply means that an iodinase, an enzyme, has attached an iodide to this benzyl ring. If only one gets attached, it's mono-1-iodotyrosine. If two, it's diiodotyrosine. Now here's where it gets fun. Of course, a protein is a long chain of amino acids, but it doesn't stay as a long chain. No, the amino acids help facilitate the folding of the protein. And if the protein folds just right, two tyrosine residues can get linked together with their benzyl rings. And if you have one tyrosine ring that has two iodides and the other one has just one, This together is called triiodothyronine. If you get two tyrosine rings linked together, and both of them are double labeled with iodine, then we call this tetraiodothyronine, or another word for it is thyroxine. And it turns out that this T3 and T4 forms are collectively together called thyroid hormone. Of the thyroid hormone that's released by the follicular cells back into the bloodstream, 93% of it is thyroxine, or the T4 form, and only 7% is the T3 form. But the T3 form is the active form. Now, it's sort of like a time-release storage capsule. Once the body uses the T3 form, that's okay. The T4 can simply be deiodinated. In other words, take one of the 4 off, and you're left with 3. And then the cells of the body can use that. Pretty clever. All right, so students oftentimes say to me, wait, how does that 4th iodide get removed? Well, there are enzymes in the target cells of the body that can remove that 4th iodide and just have 3 remaining to convert it into T3. If you remember in our first segment, I told you the possible fates of hormones when they're released into the bloodstream. And one fate that I listed was some hormones have to be activated. Well, thyroid hormone is an example of that. Here is an expanded picture of a follicular cell. Let's orient ourselves. On this side where you see the iodide pump, this is where your blood vessel would be. And this very invaginated and extended side of the cell membrane, this side would face to the right of your screen that colloid space. Now inside the cell there's gene expression, of course. The cells are using a gene and making messenger RNA that goes to the endoplasmic reticulum, and that's where the messenger RNA is translated and we get this thyroglobulin, big protein precursor. This is then exocytosed out to the colloid space. It has to, because that's where these enzymes that are responsible for attaching the molecular iodine, they're going to convert it back to an ionized iodide, and then an enzyme has to attach it to the tyrosine residues found in thyroglobulin. And again, as I already told you, we can get all sorts of combinations, 1 or 2 or 3 or 4, and even mirror images. And all of this gets, the cell will drink this. It's called pinocytosis, a kind of endocytosis. So it drinks this protein soup, turns it back into a vesicle with colloid in the middle, and inside there are enzymes, and they're going to chop up this big protein and release only the forms of thyroid hormone that could be usable, either directly T3 or T4. This reverse mirror form can also be released, though it's useless to the target cells of the body. It'll just be recycled for parts. A drug that we use clinically is called propylthiouracil, and this blocks the peroxidase and organification steps on the apical side. We do use this clinically, and I encourage you to look it up and discover why we use this clinically. And it is basically going to disrupt the synthesis of thyroid hormone proper. To my physiology students, I ask you to read what TSH does to the thyroid gland, specifically to the follicular cells. And I want you to read it because I'm just going to summarize. But everything you see here, every step gets increased in scope. More enzymes for the organification, more gene expression, more exocytosis, endocytosis. Students make the mistake that TSH merely stimulates the cell to release more T3 and T4. No, everything here is revved up in scope. In fact, even more follicular cells are born. There's more mitotic rate, and you get a larger gland because of more cells. That's called hyperplasia. And not only that, the ones that are there get bigger, and that's called hypertrophy. So a person with excessive TSH release can get this hyperplasia and hypertrophy of the thyroid gland known as a goiter. What are the actions of thyroid hormone exactly on target cells, and what are the target cells of the body? Well, down here, you should summarize this slide as virtually every single cell in the body is a target cell for thyroid hormone. And depending on the specific cell that's being targeted, we can then and only then itemize a response. Cardiovascular, for example, increased heart rate, increased force of contraction, more blood flow, etc. Central nervous system, neurons have more neural activity, more action potentials. And when someone has excessive thyroid hormone, oftentimes they'll say they're so tired but they can't sleep because they can't turn off their brain at night. They just keep thinking and thinking and thinking. In a generic sense, when cells bind T3 and T4, and I told you they have an idenase, they can convert it to the active form, we see that all of the activities of the cell, all of the metabolic pathways gets increased. We even see more sodium-potassium ATPase activity. And when someone has excessive thyroid hormone, a result of that activity of the ATPase is the loss of energy in the form of heat. And so we say there's a thermogenic effect. So this slide is just to, in general, summarize some of the effects we would see due to thyroid hormone. Now, my students oftentimes say, now Kara, we were playing the game of would the hormone levels be elevated or lowered in the patient's blood? And they say, how can we actually quantify this? Well, back in my day, because I'm pretty old now, we used something called radioimmunoassay, and I show you a picture of how we used to do this. And it still is around today, but it's kind of antiquated, and it's pretty expensive, and you need radioactivity, and we don't really, we're trying to go green, we scientists. We're trying to get away from it. We do have a good alternative called an ELISA, or enzyme-linked immunosorbent assay. I won't go into the steps of this assay, as our Saddleback students likely learned this in both micro and physiology. Just suffice it to say that we can use these really, well, especially ELISAs, it's very quick, maybe an hour, maybe two, and you can definitely capture the patient's hormones, right here shown in the pink, and you can quantify how much hormone is in that patient's bloodstream. This is very good and very quick. Now, this picture is showing you disorders of the thyroid gland. I'm going to start with hyperthyroidism. And one example, or one way, of a person getting hyperthyroidism. This woman has exophthalmos. We see that her extraocular eye muscles are lax, and therefore her eyeballs kind of bug out. Right? We think of maybe an old actor who's no longer with us now, Marty Feldman. He had big bug eyes like this. And this is a complication from her having an autoimmune disorder. And what happens is her autoimmune disorder isn't that her thyroid gland is being destroyed by antibodies. Instead, she's got antibodies that falsely stimulate the thyroid gland. These are called thyroid stimulating immunoglobulin, TSI. Thyroid stimulating immunoglobulin. These bind to receptors on the thyroid gland. And my students say, what receptors? The same receptors that bind TSH from the anterior pituitary. So these are like a skeleton key binding to a receptor that they really shouldn't be able to bind to. And this poor thyroid gland, it doesn't know the difference between TSH or TSIs bound to those receptors. It's just going to obey. And so now you have a thyroid gland that's making excessive thyroid hormone. This will feed back and negatively inhibit the hypothalamus. This will in turn shut down TRH, not shown on the screen, and in turn will shut down TSH. But this woman is still making these antibodies, and they will keep falsely stimulating the thyroid gland. So this is again an example of negative feedback inhibition failure. Another way we can get a disrupted HPT pathway is a tumor, and we covered this already. If any one of these three glands has an over-secreting tumor, it will ultimately lead to excessive T3 and T4 and lead to hyperthyroidism. What about hypothyroidism? Well, this woman over here, she has an autoimmune disorder. She has something called Hashimoto's thyroiditis. In this case, her immune system is attacking her thyroid gland, falsely stimulating it. Not falsely stimulating, and attacking it. Now, my students look at her and say, she's got a goiter. And then we look back here and we see this lady, and she also has a goiter. And my physiology students will say, wait a minute, can't we use a goiter to say if someone has hyperthyroidism, and that's a diagnostic tool? No, it's not. Anything that stimulates the thyroid gland, whether it be TSH or TSIs, that's going to stimulate the gland and can cause hypertrophy and hyperplasia. Well, why does this woman have hypertrophy and hyperplasia when I just said that her thyroid gland is being attacked and destroyed? Well, let's start at the early onset of this disease. She has a thyroid gland where the immune cells are attacking her gland. Some of those cells in her thyroid gland start to die. Are you following? There are fewer follicular cells left. Thyroid hormone levels start to go down. Use your feedback. What would happen to TRH? That would go up, trying to get more thyroid hormone to compensate for this reduced blood level. In turn, TSH would go up. And that means for the remaining healthy thyroid tissue in this woman that hasn't been attacked and destroyed yet, it's going to respond to this now much larger dose of TSH, and those remaining follicular cells will hypertrophy and even have hyperplasia, create more of them. But it's a losing battle because eventually her immune response is going to win and kill off those cells. Iodide deficiency is another unique way where we can get hypothyroidism. And yet again here we see a goiter in this woman. She's got endemic goiter. That means she has a lack of iodide in her diet. And remember, to make proper T3 and T4, we need to have iodide attached to the tyrosines. If you don't have enough iodide in your diet, you don't get to attach anything. So her poor follicular cells are being stimulated more and more by TSH. Why? Go through the feedback. Her TH levels are going down because she can't make it right. Feedback to her hypothalamus, her TRH levels would go up. Her TSH levels would go up. And this would keep stimulating over and over her thyroid gland. Give her some iodide, the hormone levels will go back to normal levels, and her cells, from lack of that excessive TSH, will atrophy. They'll actually shrink and reduce in number. So this is reversible. She just needs some iodide. This poor baby has cretinism. Now this is a problem with this baby being in utero, and the mom had a thyroid hormone deficiency. You see, when this little guy was developing, his brain was immature, his thyroid was immature. He couldn't make his own thyroid hormone. But he needs thyroid hormone for proper growth and development. So he relies on thyroid hormone crossing the placenta and entering his blood, coming from mom. So if we don't have enough thyroid hormone, I'm here to tell you, during development, neuronal development does not occur properly. And so this baby will have mental defects because of his mom's thyroid hormone deficiency. Just to identify some of the words that you see on here, this woman over here who had Hashimoto's, you see how swollen her face is? She's got edema, and this is a special kind of edema called mixed edema. And that basically means edema of the non-pitting type. So if you were to squish on her face, you would not make indented regions with your fingers. And this is because of changes in glycoproteins in the extracellular matrix. And they're basically acting like a rigid sponge. They're holding water there and not letting it slosh around. So that's the kind of edema she has. She just looks miserable, doesn't she? All right, to summarize, some ways that you can have hyperthyroidism and hypothyroidism, and some common denominators are listed here in the middle. And I'm showing you what signs and symptoms you might have a patient present to you or report to you on the left side for hyper, and on the right side for hypo. And I would take some time to understand why these differences would present in your patient. And to do it again, here's how we can get hyperthyroidism from excessive T3 and T4, and hypothyroid from decreased T3 and T4. Maybe for hyper we have over-secreting tumors or TSIs. With hypothyroidism, maybe we have under-secreting tumors or an iodide deficiency or any defect in the entire pathway of making thyroglobulin and iodinating it in the cells. Maybe there's an autoimmune destruction like Hashimoto's thyroiditis. You get the idea. All right, when we come back for our third installment, I'll now cover the HPA pathway.